By the way, you're all ready to start whenever you want to.
Okay. All right. So it's a little after 1. I think we can go ahead and get started. So we're missing several people right now. Dr. Moss was going to try and join for about 20 minutes at 1 o'clock, but she might be stuck, which, I can completely understand. Um, I don't know if we were expecting, I don't think we have Yale on this meeting, right? This is not the
Yes,
action.
they
Okay,
do get invited to this, and Elle mentioned that they'd probably be joining. So
okay. All right, well, I think I'm going to go ahead and get started because we can update everybody. Lord knows we are not going to hold you for an hour and a half because that is just way too long. And I think we just want to give everyone an idea of where we're at right now after some meetings that Dr. Moss and I had, and we really went back to the drawing board of what exactly is the ask for this committee, where we are right now, because we have kind of made it a little bit bigger than initially asked for. So basically, the recommendation is due soon. We have gone down a road of trying to develop a a statewide children's program, as we talked about the last time, which would be Champion Care, which is really patient advocacy for children. And at the same time, how do we improve hospice care in the state of Connecticut? That was kind of our initial ask, and we are trying to develop a statewide pediatric hospice care program, along with developing Champion Care, as we found so many gaps in care that you kind of can't be left with just one way of doing this. We kind of need a couple of things in tandem. We also know we have the Palliative Care Coalition, that the Pediatric Palliative Care Coalition, that is running simultaneously with the Palliative Care Advisory Committee. There is going to be potentially an ask for us to have a pediatric hospice care advisory committee. But basically, in what we would like to do is continue our work, as we find, as I'm sure many of you have found who sit on a lot of these committees, the time is just not enough. We need to continue some work, but where we struggle most is, hi, Elle. Where we struggle most is obviously our data. And getting data, being able to back up all the things that we know anecdotally that happen, why we don't have proper staffing, why like hospice is that, the H word. Why do we not have enough people even going on palliative? Do we even have enough palliative care providers? Like, we know all the gaps. We know there's also work being done on Katie Beckett, right? So there's a committee working on Katie Beckett, where part of what we took on at one point and decided to veer away from that was, okay, how do we get more people on Katie Beckett? And so we have kind of stepped back from that, and we're going to let that committee do that work. But we find that as a barrier. So I think knowing what all the barriers are, and trying to get something, put together to at least present and get the nod to be able to work further on this, with a lot of data help. And Elle, that you guys have been like absolutely amazing with getting us data, but we really need to show how the care, whether it's hospice care, palliative care, advocacy, care so that people can get help in whatever manner they may need it is going to cost money. But at the end of the day, how much money are we saving on less hospitalizations, not using the emergency room? And we have struggled with actually getting data and being able to prove or show that this could be, although we may ask for money, this could be a savings somewhat across the board. At the end of the day, we need more hospices doing pediatric hospice. We need even those hospices that are doing pediatric hospice. I mean, regional being one of them. We don't do pediatric palliative care. How do we do more pediatric palliative care? And all of this is going to take help with getting nurses trained. Possibly we're looking at an initiative that would have the state help us with an incentive for nurses to even get trained in pediatric palliative and hospice care. Student loan payback. How do we get nurses enticed in really wanting to learn and gain experience in this area so that we can even staff hospices that would then be willing to, take on pediatric hospice care? I think, and Melissa, I'm gonna, punt to you too, if you want at any point, where we have kind of gone round, and I'm just being transparent, the mulberry bush of, okay, here are the gaps. Here's how we can possibly fill the gaps. And we always go back to, how are we getting the staffing? How are we getting nurses, that want to do pediatric end-of-life care? And then how do we keep them? So with all that being said, we have actually proposed, we're going to propose, and we're going to send this out to everyone and really get your feedback when you can read this and understand it better. And actually, Melissa and I have been working on it till 11 o'clock this morning, and that's why you haven't even gotten it as a draft. But we want to establish what we're calling a pediatric hospice nurse capacity grant program. All this is great, but how do we get the nurses? At the end of the day, that is really, what it's all about. We want to expand pediatric hospice nursing access through, pediatric skilled licensed hospice agencies who will respond to the needs of medically fragile children with life-limiting illnesses. We want to begin to build a framework for a more comprehensive, and I'm just reading off of this for you, more comprehensive and dedicated program through which a centralized coalition of care will offer a child-centric view to ensure that all the needs of the child and their family are met to support the medical and psychosocial health and longevity of the child. This framework will include exploring legislation that will pursue methods so that all facets of the child's care would be supported, taking into consideration current programs, payer options, and expanded care. And we have gone down a litany of, do we even ask for a payer mandate? And, and then we're told, well, less than half of those are insurances that we can't mandate them to do anything in the state of Connecticut. So it's okay. Well, that would be great for about maybe 30% of the entire population of Connecticut, but not for the other 70%. We cannot mandate that they have a hospice benefit, pediatric hospice benefit. We cannot mandate that they give a hospice benefit and then also provide concurrent care. So your hands are kind of tied when it comes to that area. do we look at amending bills, which, as all of you know, and probably more so Elle and Tracy, and Barbara, that we need years of work in order to do any kind of amending of bills or trying to put new laws, in effect. We are asking that the State Assembly Public Health Committee continue to champion the efforts. This is going to be our ask in the proposal going in, to enhance the outcomes of our fragile pediatric population. We are, going to ask that, do we make this now a Pediatric Hospice Advisory Council? We want to also, there's going to be funding here. We've had people that have been meeting with us, over the past months that have said even their time participating in something like this is costly to some of those who work either for health systems that are looking for, what is in this for us, kind of. It's becoming a framework that we would like to launch over the next 2 to 3 years, but it's also going to take the approval of millions of dollars. So all that being said, I'm sorry that we did not get this draft to you before now, but as I said, this has been, work in progress for many months up until this morning. And we can, get this out to you and welcome, any comments. I think that I'll probably read to you the overall summary, which was, on March 2025, based on sponsorship from the Public Health Committee, the Connecticut State Assembly created Public Act 2419, which empowered a dedicated working group to continue development of a solution to address critical hospice needs of medically fragile children with life-limiting illnesses. This working group has been meeting over the past 5 months and has researched and identified current gaps in provider care, limits on skilled resources, and the negative impact these challenges have on families to care for their children. These gaps include barriers such as insufficient number of nursing resources, limited geographic access to services, lack of certifications and licensure restrictions due to hospice definition parameters, limits with insurance payer sources, limited access to Medicaid, limits to the scope of care received, and lack of continuity for services provided. And I have to say, if there's one thing that I learned through this process is that I have no idea the true definition of concurrent care and hospice or palliative care. Thank you, Jessica Pope, for really trying to bang this into our heads and get a sense of, and I think that will only come with time, right? That part of some of the gaps are things are truly concurrent care and should be covered separate from a hospice benefit. And I think that's where we struggle a lot also. So again, I know I'm preaching to the choir here. I know we have heard the gaps in care and we completely understand what they are. I think at the end of the day, what we're really asking for is more time, more ways of data, to open us up to more data so that we can show just what we're spending. And thank you, Regina, for actually the Medicaid, the Katie Beckett spend. And again, as we went down that road, we kind of, thank you, Barbara Cass, too, for saying, hey, wait, there is already a committee working on Katie Beckett. So let's not, let's not try to start working on that when there's already a committee working on that and we can support it. And we think about the potential, even if there's more people that get on Katie Beckett, where are the services coming from?
Tony, I think Regina
Yes.
has a comment or question.
No, I don't. I was just applauding what she said.
Oh, okay. I thought it was a
Oh.
hand raise, but it's an applauding.
Oh,
Yay.
thanks. Thank you. Thank you, Regina. So that's pretty much where we're at. I will open this up to any questions. Like I said, I'm happy to send this out to everyone. I do have a call planned with, and her name, I'm actually have to go to the text and I apologize. She is the lobbyist for the private payers. Where's my text from her?
Hey, Tony Ann, I think while you're looking at that, if I could just recap, we
Go
know
ahead.
that so much great work is being done by various committees and external organizations. And I think our focus is to take advantage of all the progress they're making and see how we can integrate it into a hospice-focused program and platform rather than trying to duplicate. So this, all the different discussions with the folks in this team have been incredibly illuminative to help us understand what's going on out there and what's happening and the work that's being done. So not trying to step over each other or trying to duplicate, but really trying to connect the dots with all the different things going on, but have this be pediatric hospice focused and understanding what's going to be needed to move this forward. And as Tony Ann, it's a multi-year process. So none of this stuff is going to be done in the next 3 or 6 months or even a year. It's because of all the different work streams going on, as well as the things that need to happen in order to put something in place that truly has impact and quality to address the needs of these children. So
Thanks, Melissa. I also want to say it's Susan. So Susan, I'm not sure of her last name. She is the lobbyist for the health insurers, and we're going to have a call on Friday because just to be able to understand, if the percentages are so different. Hello, Senator Anwar.
Hi, sorry for being a little late.
No. If the percentages are so different, then why, which road do we want to even go down when it comes to private payers and, hospice benefits? And Senator Anwar, just to bring you up to speed where we're at, we just did a real general overview of where we're at. Where this has ballooned to and kind of where we're bringing it back down to. You get a bunch of great minds all together and we want to save the world. And, so we're bringing it back down to trying to do something basically in tandem while developing a framework for what we call CHAMP care, which would be, advocacy for all, medically fragile children in the state of Connecticut, and have that sort of be a coalition for anything that a family may need, direction. They may need help with deciding on, where do I go for home care? Where do I get my shift nursing? Am I ready for hospice? Is this palliative care? How do we work with being able to handle all of those needs with just being able to direct families of where they can find this help? At the same time, trying to develop a pediatric hospice program in the state of Connecticut that will allow us to handle the number of children we feel we would have to handle once, not to, use this phrase, but open the floodgates, so to say. How do we build a real educational infrastructure that can support teaching providers, the public, what hospice really is and what it means for a child in the state of Connecticut if they were to go on to hospice with having concurrent care. They can be on hospice and, as you know, still have concurrent care. How do we educate that hospice is not the big bad H word? And then how do we absolutely provide it? And that's where we're answering the questions of how do we increase nursing? How do we increase the training of the nurses? How do we get more hospices to do hospice care? So those are all the things that we're actually addressing and that we're putting into our final recommendation. I'm hoping that by the time we have the final recommendation, that we also have some answers to those recommendations that we're making, that we're recommending this, and if we do this, that can answer that gap. So I just want to let you know where we're all at right now. It's been a lot of hard work. It's been what I have to say, the only hard thing for us has been real hard data. We'd like to be able to show why we think we're recommending these things. We don't want to just say it anecdotally. So we have struggled a little bit with data. But just so you know, it's really a hospice answer, a pediatric hospice recommendation, but also a much bigger CHAMP care that would just be able to direct families on any needs that they may have. And actually talking to someone and saying, my baby has just been diagnosed with, and my doctor told me to call CHAMP Care. And how do we direct them through this, through wherever they live in the state to get the care that they need, which could be many different things. So you're kind of getting two things out of our ask. And, like I said, I'm hoping as we get closer to giving the full recommendation, we have more answers than we actually have right now. Okay, good. I like that thumbs up. So as I said, I'm totally open for, any comments, or I know there's not that many of us on today. And like I said, Dr. Moss was called, into a case. I'd like to send out the draft so everyone can see that, which is still a work in progress. But I'm open to any recommendations, comments, if anyone has anything to add. Okay. Not that that's what I like, but I feel like then maybe I expressed where we're at. Okay. Well, and Senator Anwar, I also plan on getting something to you before we present.
Yes.
But so that's where we're at, everyone. And like I said, we will get this draft out to you. And hopefully, as in the next couple of weeks, have a lot more answers to some of the gaps. Senator Anwar, just so you know also, we've gone down a couple of different roads and then realized through great members on our team here that there are other committees working on things. So we found like the Katie Beckett waiver. Well, how do we get more people on Katie Beckett? Well, there's already a committee working on that. So we've stepped back from some of the gaps that we have found because there's already teams working on it. So we'll also put that into our report. Okay.
Tony Ann,
Yes.
I don't want to be assuming, but the whole data gap concern, have we thought at all about looking at the death, see if we can look at the death certificates of children from 0 to 18 and their diagnoses? Maybe it's, you can hone in on the complex chronic illness, et cetera. Just to see what the numbers have been over the past 5 years, whatever timeline. So you can look at each year. On average, we have, this many pediatric cases in Connecticut that die because of these advancing illnesses.
That's an amazing comment and really good idea. And my question would be, Elle, is that something you could help us with? Regina, is that more like in what direction do we go in? Elle, I see your hands up.
Yes, just briefly, the Salmon Center team put together a short white paper a little while ago on this idea. It's a bit of an unusual option, but we do suggest that there potentially the Connecticut legislature could expand the existing maternal mortality review committee or the existing infant mortality review committee or alternatively create another similar review committee that would be looking at this data, because those review committees have been shown across states to really have a fantastic, very useful methodology for collecting this data, and also for just going beyond medical records and making sure to kind of get those underlying narratives that kind of sit between the words in, a death certificate, and then also turn whatever is collected from those cases into policy. And I haven't been able to find a lot of data on Connecticut's maternal mortality review committee, but in other states, I know that there's been some pretty substantial integration of the review committee into other efforts. And that seems like it's been a very successful model for not only initial data collection, pulling that information from death certificates, but also figuring out what that means in the aggregate and how that information should inform policy decisions. So I'm happy to circulate that. It's a very just kind of like maybe white paper, but just in terms of having a standardized method that's already there. There's some material from CDC about this in the mortality review context, but it's easily transformed into other, it's not specific to maternal health. And so that's something that I think could be up and running fairly quickly, although obviously it would require an additional expenditure from the legislature, either to expand one of the existing review committees, I'm assuming potentially infant mortality. But it's not like an easy fix, but I think it would be like a medium term, medium effort, medium expenditure option for data collection.
Well, I asked that mainly because from what Tony's saying regarding potential, Tony Ann's saying regarding potential recommendations is to focus on the hospice with concurrent care versus the palliative, because hospice would indicate more end of life. And if we actually had a volume of not, how many and what the issues were, what the actual diagnoses were, it might help drive us to know what the numbers are. Certainly you could track where they exist in the state, but from one year to the next, it's not going to drive you to make decisions on where you need to
Right.
provide care. It's
Right, and
really just to give you volume.
Yeah, so Elle, I totally appreciate that. I'm thinking, what is like the right now? If I mean, the death certificates exist, right? I'm just not sure where we would go to get that information. And I don't know, Barb, if you seem to be also, I mean, maybe you and Tracy, like, where could we even go to gather that data, if anywhere?
I am thinking, and I haven't a well-formulated thought, Tony Ann, but I don't know if we could collect death certificate information. I can check with our vital statistics unit to see if there's any ability to create a report that could filter out, excuse me, deaths under 21, and then if they can further filter to, maybe to Tracy's point, cause of death. So
Yeah.
let me take that one, and I'll report off after I do a little bit of research at DPH.
And I think, Barb, it would be under 18 and under, so under 19 for the definition.
Is that what we're
Wouldn't it?
using?
I think
I'm
21 is
in
the
the-
definition.
Would it be 21?
Yeah.
DCF,
Okay.
Concurrent care
21
goes
now.
up to 21.
Okay.
I will say I went online, did AI searches. You can get a lot of data reported at national levels, but less data reported at Connecticut. Specifically, some states, as Elle said, do report out that type of data, and other states do not. And I think Connecticut, there's nothing online specifically to say, here's what Connecticut reports. No reason why it does or does not, but it's not necessarily easily searchable.
And we have the electronic
Yes.
registry now too, so that it may
Right.
be easier to pull. I mean, I mentioned like go back 5 years and just get the trends. You wouldn't have it for 5 years, but you would have it at least for a few.
Yes, and if I may just really briefly, I'm so sorry, is that I believe other states, this is normally done inside the government just to make sure that just not getting around, but adhering to those privacy laws. I believe it, regardless of, whether the state was to move forward with, a mortality committee review, that whole structure, I think there's a nurse, usually a trained nurse, but not necessarily someone with that training, who is already employed by a state government. And that is the person who's responsible for anonymizing and gathering all of that data. I'm happy to pull some extra information that we found from our research, just about that, in the right now, like short term, pulling that information with death certificates, if helpful, if it would make sense to just have a look at like what other states have done, just for getting that basic vital stat information.
Because that way you're eliminating the payer issue that we were
Right.
talking about. You're actually just looking at all deaths.
Right.
Mhm.
So then
Right.
the numbers are very small. Nationally, the death rates for pediatrics under 1 year and less are due to congenital malformations. From 1 to 18, 19, 21, it's due to injury, unintentional injuries. That's the number one cause of death. I think what we're really looking to uncover is who's living with serious illness, who's hospice eligible. And I don't think that's being captured currently in the state of Connecticut. And to support your thoughts, Elle, it's going to take a committee to actually look at who's living with serious illness, whether it's oncology or some of the other life-limiting conditions. It's going to take some work and some tracking of what are the illnesses we're looking to uncover. So I think broad strokes will be disappointed at the numbers aren't warranting hospice care. But if I think we peeled the layers of the onion down, we'd see, oh, wait a minute, yes. There are infants in Connecticut who are living with very serious medical conditions, rare genetic conditions, and they would qualify for hospice, but we're not collecting that data. That's my understanding.
Yes. Yeah, I'm in agreement, Eileen, and like what you're saying too, it's like it feels like it really does take a village. I mean, it's so many different things that need to be worked on. I do want to think of, I was thinking even on our own data, or like even if other hospices, which, I can reach out to, there are some other hospices that are very interested in an update, here, that maybe if they've taken care of pediatrics, what have they seen? What are, or even some of the health systems who are discharging these kids home, what are they seeing? What are the top 10? And I think we tried to get there once before. What are even the top 10 things we're seeing that really are that these kids are not going to live to be adults, and we know that. So that would be, that would be great information to have. But I want to try and work on something with the birth certificate kind of pathway. But what department is that even in? Like who oversees death certificates? Barbara Cass, I see that hand.
Not me personally. I want to be clear, not me personally. But we do have a vital statistics program at DPH that does manage all death certificates in the state. And as Tracy indicated a few years ago, we transitioned to an electronic registry platform.
Right.
So I can check with a couple of pathways at DPH. I can reach out to the death certificate unit, Vital Statistics, and they also within Vital Statistics have a there's an epidemiological unit that collects data. So let me see. And again, this is outside of my wheelhouse. So I'm
Absolutely.
randomly talking. I don't know the nature of their work specifically. I just know they do this work. So vital statistics, the epidemiologists that collect diagnostic data. And then I'm thinking, and Tracy, I wonder if Adora and the BRFSS program, the Behavioral Risk Summary, I wonder if they collect any data. So let me check with the individual who oversees the survey program that they do in collaboration with CDC to collect data. It's a questionnaire, it's done by telephone, and it's a series of many questions.
Okay.
So I have
Yeah,
those
and
three
if you
pathways
can,
I'll work on.
I'm sorry, I'm thinking that maybe we're making more out of this than my original question. I really do think that the department within DPH that manages the death certificates is responsible for putting forward an annual report that probably goes to the CDC, because the CDC has to report out on deaths every year and what the most common diagnoses are, ages, et cetera. And I'm thinking that data must be available if we
There's a
FOI.
web page, Tracy, and I just looked at the web page where they provide data analysis. I just don't know how detailed and the specificity of it. So I'll do that
Right.
outreach. It's not
Okay.
complicated.
Yeah, and we can also, Melissa and I'll be more than happy to look into that a little bit more. And if you want to, if there are any contacts that you'd like me to reach out to, I'm happy to do that. But I'm also interested in looking at it ourselves. That would be very interesting.
I think
I'll
just
do the initial outreach. Sorry, Al. And then I'll follow up with you, Tony Ann.
I think short of having the data, and I think all of us, I'm not counting myself in this, but all of you who work in this space know that there are sufficient numbers of children who need this type of care. We know what the issues are. We know we have ideas about protocols and steps we'd like to take to address these issues and get a footprint out there, so that families and children have the resources and care that they need. So I think that on the knowledge side, we have a industry and experiential knowledge of what the right thing to do is. I think for us, we just want to make sure that we're representing this appropriately to the Public Health Committee, so that they, it's clear that the breadth and the depth of the issues that exist. So I don't think there's a question about what needs to happen. I think it's sort of making sure that the data is there to send the message home.
I just wanted to say one other thing. It doesn't, the hospice doesn't have to be the end all be all here. But if we could even get more palliative referrals, we have to also look at how are we sustaining that care, palliative care, with the payment structure that there is for palliative care right now, right? So how do we do that? So that's also, going to be a part of, it's not, just all the hospice, but we have to improve hospice care in the state of Connecticut. And then on the same, in the same framework, how do we, if palliative care is more palatable, so to say, how do we get better payment structures towards palliative care? How do we sustain that kind of services, also? It's kind of a culmination of things, as those of you who've been sitting with us week after week have heard. Any other comments, or go ahead, Melissa?
I think Regina and Barbara both had their hands up.
Oh, I'm sorry.
Offer comments. That's all right.
Yes, hi. So this is Regina. I was just thinking as everyone was pitching in and speaking, and I know I'm going way out there, and it's not like comparing apples to apples, but I was wondering, like a state of Memphis with St. Jude's Hospital, Children's Hospital there. Do we, do we know what kind of data they collect or how they collect? And again, I know it's a private entity, but I was just, my mind was just wondering as everybody was talking.
Yeah, and that's something that's a great thing to consider. So I love that you're saying whatever comes to your mind, because everything is helpful at this point. Barb?
Thank you, Tony Ann. And I just wanted to expand on your comments regarding palliative care as well, pediatric hospice / palliative care. I think, as Eileen has identified, the number of children that pass away is a small number, but we know the number of children who are living with life-limiting or chronic diseases is much, much higher than the number of children that pass away. So that still needs to be a focus of the work that we are doing here. And it also will align nicely, I think, with the work that Eileen is doing with the Pediatric Coalition. So thank you for bringing that up. And I don't want us to lose sight of the importance of palliative care here.
No,
Thank you.
and yes, and I absolutely get it. Where we struggle sometimes is understanding that sometimes the reason for the lack of palliative care services is the payment structure, right, of palliative care. Now, we have a very good payment structure for hospice, but people don't like to do it because it's hospice, but we have concurrent care. This is where I always go, and like Jess, help me out here. Like, we have a benefit that if we could just get people comfortable with it, right? Because it is palliative care. But if we could get people more comfortable with it, they could have that benefit and still have life-sustaining, interventional care. Because at the end, right, it's palliative. So that's where I own, like, I feel like sometimes that when I think about personally here doing palliative care, I know I can't sustain true palliative care. I can't, unless I had 50 patients on it. Maybe I could sustain it then, but I can sustain hospice because of the hospice benefit. And for a child, they can come on and still get everything they're getting when they're on palliative and have the hospice benefit. So that it's just the sustainability, basically, for me. And Jess, I don't know if you have any comment on that.
Her phone is.
Sorry,
Yeah.
I'm trying to pull up the unmute button. No, I mean, I think that there certainly is still a line that is drawn between palliative and concurrent care, but the accessibility is so much more, and families and providers as well. They don't realize the true scope of support that can be offered through that, and recognizing too that hospice model is one of the highest, most patient person-centered models of care you can get in healthcare, and being able to offer that, it has so many positives, but it is that barrier of getting through the H word that can be very difficult. But certainly hospice, as we know, encompasses palliative care. That's a part of that mission. And I think that the education across the board to anyone involved in a child's care, whether that be a parent, a friend, a provider, an agency of any sort, that's really what helps with that sustainability, and truly just accessibility to care as well. I think you did a great job, Tony Ann.
Thanks.
I think one of the things in this model that we're recommending is that everybody gets brought to the table at the same time. Different groups do different services based on what their qualifications are and what's necessary for the child, but the family has all these services available at the same time. So if the circumstances change, if the condition changes, they have access to the different range of services. So.
Thanks, Melissa.
Yes, I would just like to say, just unfortunately, again, lawyers getting in the way here, is there's a really, really hard ceiling on hospice eligibility from a legal standpoint. And unfortunately, it's at the federal level. We've been doing a lot of work here just trying, and I know other states have been expanding concurrent care. But because the Medicaid hospice benefit specifically is so tied to the Medicare hospice benefit, and then the Medicare hospice benefit is really driving the hospice, the shape of hospice and care delivery at a very high level. That means that I think, unfortunately, you know, if you had a child with, say, sickle cell, even if that child could really benefit from, you know, hospice specifically and, you know, that sort of level of care, I think it's very unlikely that we'd be able to see reimbursement for a child, maybe one child with sickle cell, but it's still going to be very ad hoc, because at the end of the day, going back to the 80s when the hospice benefit was being considered at the federal level for Medicare, and then we see it happening again for Medicaid a few years later, it all came down to cost effectiveness. And so that sort of really awesome payment structure is in place because Congress decided, like, oh, well, this is going to be a very small number of people. And so I think for those of us, I think, you know, they keep poking at palliative care, is that if there's a way to develop a separate palliative care benefit through a state plan amendment, which actually New Mexico just decided to hop on that train, is that's unfortunately potentially going to be the reality here, because I think although there's room to expand hospice as it currently exists, I think that we're still going to run into that ceiling, because in federal law and federal regulations, it's still very much an end of life, not like prepping for end of life, but really an end of life care type of, you know, model. In when we're talking about payment and when we're talking about annoying lawyers, even if that's not the reality on the ground. And so I think, like for us Solomon Center folks, we're still really trying to find ways around that. But at least from the lawyer perspective, which we understand is limited, beside if there's an expansion of the hospice benefit to a year, and then making sure more children can receive concurrent care under that model, that'd be awesome. But we're really not sure if there's a way to expand hospice beyond that to really encompass all children with life-limiting illnesses.
To your point, Ellen, I think that's great to give us really good insights into some of the huger barriers. I think this is like a multi-year process. And so some of these things we may make progress on faster, and other things will take a lot longer, and obviously dependent on what the federal government might make versus what the state can take action on. So it's very complicated, and I think we need everybody's help in making sure that we kind of continue forward progress, but we may not make progress in everything as we would envision it, you know, the outcome to be. So.
Right. And again, it's, you know, and I don't want to use this as my soapbox, because at the end of the day, it's what's best for kids in the state of Connecticut and how do we get there. Getting them more services, getting them on, you know, Katie Beckett and things like that. At the end of the day, you know, the terminal diagnosis and having 6 months or less is also clearly defined as if the disease was to take its natural course. And, you know, I have kids that have been on hospice for a couple of years, and it's, you know, it's because of concurrent care. So more, I mean, we could bat this back and forth, like, you know, all day long, but I just think really trying our best to do both things at once, make palliative care sustainable for, you know, for an agency to even provide palliative care. And then also, how do we educate more on pediatric hospice, not hospice in general, because that is, you know, totally different, but pediatric hospice. So, and that's why I miss hands, because for me on my thing, does everybody's jump around a little bit? Like, or everybody stays in the same spot?
It's moving around, and Barbara's got her hand up.
When
Okay.
somebody raises their hand, they go up to the top. left
Oh,
corner.
thank you, Tracy. Okay, Barb.
So, thank you, Tony, and thank you, Melissa. Just a quick comment that I don't want to lose sight of. We've talked about training and the barriers that limited training or limited nurses with hospice training has created. We've spoke about the sustainability through reimbursement, but I don't want to lose sight of the discussion the subcommittee had related to care coordination or navigation, where we know there are lots of services that may be available, but and again, it wasn't lost on me early in our work group when one of the moms who had been living this kind of trajectory and had indicated that had she known about regional hospice earlier, how much better her life would have been. So I think we just want to continue to talk about care navigation, care navigators that can help support families at the very beginning when they're starting with this I don't even know how to characterize it, but when these life-altering events happen, what's out there that can help support families? Thank you.
Totally 100%. That's why I said we're kind of handing over this big package, because I think that is, I think that's important that, we have something that families can turn to, whether they want hospice or palliative care or neither, to be able to call and be directed for anything that they're facing with a, medically complex or medically fragile child. They may be directed in, they may just need a therapist. They may just, you don't know. So yes, totally, and that to me is what Champion Care is all about. But at the same time, it's just working with how do we raise the other things and the potential of continuing. So totally agree. Antonia.
Hi, I'm Antonia. I'm interning with Representative McCarthy Vahey. She sent me in to listen to the meeting and take notes, not to be confused with Tony Ann. We have very similar names going on. But I just wanted to clarify something I'm going to tell her about I know you said that a draft would be sent out, but I just wanted to clarify. So this proposal, it encompasses both the sort of program for the centralized coalition of care for the nurses. So that's like a pathway of education around palliative care. And then this also this encompasses the advisory council as well.
So basically what it encompasses is we are looking at having a whole kind of state, like a Champion Care that would help with any child that's medically complex. But then also at the same time, how do we answer the gap of pediatric hospice in the state of Connecticut, pediatric palliative care in the state of Connecticut? How are we answering those two? And like the draft will probably be really helpful for her also and for you. So yes, you're correct.
Okay, thank you so much for clarifying.
Absolutely.
Antonia, after you get the draft, if you have questions, I'm sure Tony Ann or I would be happy to fill in any details. So.
Okay, great. Thank you so much.
Absolutely. Any other comments or Jessica Pope, you okay over there? Okay.
I am, yeah.
All right. Anything to add before we close out?
I don't think so.
Okay.
Thank you, everyone, for all you do. Thank you so much.
Yes. Senator Anwar, thank you for joining us today.
Of course.
Nice to see you.
Good to see you.
Okay, everyone, look for the draft. It'll be coming out this afternoon. And then if there's any additional comments or anything, just please let us know.
Thanks,
Thank you
Tony Ann.
all.
Thanks, Melissa.